Well, thank you for joining us, everyone. It is a pleasure to be here with you guys today. I'm excited to be discussing a very important topic with all of us this morning or afternoon, depending on where you're at. We're talking about treatment options and acute hepatic porphyrias. All right, so without further ado, I would like to get on going to Dr. Sioban Keel. We are very, very fortunate and blessed to have Dr. Keel as one of the porphyria specialists and experts, and also member of the UPA's Scientific Advisory Board. Dr. Keel, thank you so much for making the time for us today on a weekend, nonetheless, to impart your knowledge and to answer all the questions that we have about AHP treatments. With that, let me turn it over to you. Take your time and give us your brain. Share with us.
Great. Well, thank you, Myra, so much for the introduction. Just as a little background, my name is Sioban Keel, and I'm coming to you from Seattle, Washington, and I work at the University of Washington in Seattle, and I see patients at the Fred Hutch Cancer Institute. And this is a picture of where our clinic is on a somewhat rare event, a sunny day in Seattle here, and this is Mount Rainier. So it's nice to be here with you. And I really just put together a short little talk to give an overview of the hepatic porphyrias, the acute hepatic porphyrias. That's going to be the focus today. So just my disclosures, I am on the advisory board for disc medicine. I also get clinical trial support from a number of pharmaceutical companies in diseases in the porphyrias. So I always like to just step back and make sure everybody's on the same page. I know all of you are dealing with this disease in some way or another. And so I like to give a background on what's this about. And the analogy I usually start with is I kind of think of the porphyrias a little bit like these diseases are due to a problem in a number of steps in a recipe. So just like you might have a recipe to make, let's say, a cake, there are 8 steps in the process of making this cake. The porphyrias, the various types of porphyrias, are problems in a recipe that the end product is making heme. And heme is the compound that binds with something called globin and carries oxygen in your body and has other functions. And so there are 8 steps in this recipe to make heme, and all of the porphyrias are a problem in one of these steps. One of these steps doesn't work. And so there's an accumulation of the ingredients in that recipe before the block. So now when you look at this in a little more detail, this is the liver. And what we're going to be talking today is the acute hepatic porphyrias. Hepatic just refers to liver. And this is in the liver cell. This is kind of a schema of a liver cell. You just see the steps of that recipe that I talked about. And I wouldn't worry about all the complexities of the different organelles in the blood, in the liver cell. But the idea, again, is that in these 8 steps, the acute hepatic porphyrias are each a problem in one of the enzymes, one of the steps in this pathway. And when you have a block in one of those steps, you have an accumulation of these 2 things, ALA and PPG. And those are what account for the symptoms that people suffer. And those symptoms you all are familiar with. Patients can have acute symptoms during an attack. And most commonly, the acute symptom is pain in the abdomen, nausea and vomiting, or weakness. But unfortunately, patients can also suffer from a lot of chronic symptoms. And what I'm just showing here is one of the longitudinal studies that looked at what are the most common chronic symptoms that patients that have acute hepatic porphyria suffer from. And you can see that people have chronic pain syndromes that can last, mood disturbances that can be difficult. And what I'll also just highlight here is, in addition to these symptoms, there are a number of associated medical conditions. So patients can develop peripheral neuropathies, numbness or tingling in their fingers and in their feet. High blood pressure is associated with individuals that have hepatic porphyrias, and people can have chronic kidney disease too. So we're really thoughtful over a person's lifespan about protecting their kidneys from other insults. So I'm going to kind of take you through now, well, what causes an attack? And I think the reason it's good to have an understanding of this is one of the things we're real thoughtful about is how do we prevent attacks? And this gets at that. So again, what I show here is a schema of that recipe to make heme. So again, these are the steps with the ingredients. You start with these two ingredients and you end up with heme as your final product. And I just put here the particular steps that are defective or abnormal in an acute hepatic porphyria. And what I want to highlight is that making this heme, the most important step or the rate limiting step in making heme is the first step. It's the first step in the pathway, in the making of the cake. And that's an enzyme that's called ALAS1. It's in the liver. And there's kind of a couple of things to know about how this enzyme acts. One is that the end product of this recipe comes back and turns off ALAS1. And so when you make heme, you turn off the first step in the pathway to make heme. And then there are also things that can turn that pathway on. And an example of that is if a person's fasting, if their blood glucose drops, that turns on this enzyme here. And so what are other things that can trigger an attack? Well, the things that can trigger an attack all act by doing one of two things in this pathway, you guys. One is they act by reducing the end product. They reduce heme synthesis. And the reason that works is if you reduce heme here, that inhibition or the negative feedback on the first enzyme is pulled off. So you get an increase in that first step in the heme synthetic pathway. And there are also, alternatively, other than dropping heme in the cell, you can also have triggers that directly affect the activity of this enzyme. And so in both of those settings, whether it's the heme drops in the cell or the trigger directly affects the enzyme, this enzyme's activity increases. And if a person has a block, has a problem in one of these other steps in the pathway, when you turn on the faucet into that pathway, what you're going to see is an accumulation of the intermediates prior to that block. So the example here I show is a person who has acute intermittent porphyria has a problem in this step in the recipe. When you turn on the faucet and you hit it against a kink, you have an accumulation of ALA and PPG. And those are toxic to the nerves. So again, these triggers that either drop heme or directly turn on this enzyme are things like alcohol can do it, certain drugs that are, not all drugs, but certain drugs that are processed through a group of enzymes in your liver, fasting, infections can do it, progesterone, so hormonal changes that might happen in an individual who menstruates, and smoking. Those are all triggers that work by either dropping heme or directly turning this enzyme on, and you get this accumulation of ALA and PPG that are toxic to the nerves. So I'll just kind of quickly go through some of the treatments that we have for the AHPs. And I'll just highlight one thing. As a community, there have been a lot of efforts to standardize care for our patients with AHPs. And kind of the most recent update on clinical practice guidelines was just published in 2023. So I think that's a nice thing in the field, that people are staying updated and saying, hey, how should we take care of patients best? So I broke this down kind of into a few things. One is, how do we treat an acute attack? And I think the most important thing is that you discontinue the triggers. And we just went through those. If there's medications that might have brought on the attack, if a person is having attacks repeatedly during their menstrual cycles, right before the onset of the menses, we can make considerations there. We want to have patients avoid long periods of fasting. And so small intermittent meals or snacks are important for our patients. And then also the treatment of an acute attack, we use a drug called hemin. And so hemin is that end product. So if you kind of remember back to the schema of the recipe I showed, I said the two mechanisms by which the triggers cause an attack, one was that you drop heme. And so you end up turning on that first enzyme. And so we can give people back heme in an IV formulation that's called hemin. In Europe, the formulation that's approved is called hemarginate. That's not available in the US. In the US, we have panhematin. And the indication for this drug is an acute attack. It's generally put into a solution of albumin, and it's given as an IV. And so really the main side effects that we see in our patients that get panhematin is it can cause a local reaction in the vein, what we call a phlebitis in the vein. So we're thoughtful about using a large bore IV to avoid that. It can cause a little bit of changes in your clotting factors. That's typically not a big deal. And then the other thing I point out, because some patients get hemin over a lifetime, is there is iron in hemin. And over a lifetime or many repeated doses of hemin, you can develop iron loading, but it takes a long time. So let me just put that into a context, because I don't want you to worry that there's a ton of iron in there. Most people get hemin at a dose of 3 milligrams per kilogram. So that's someplace around, in an average size person, 200 milligrams or so of hemin. And in each 100 milligrams of hemin, there's 8 milligrams of iron. So maybe in a dose, you're getting 16 milligrams of elemental iron. That's not a ton, you guys. And so when you take an iron supplement at home, let's say you're iron deficient and you take an iron supplement, most of those contain about 45 milligrams of iron, of which you absorb about 4. So this is not tons of iron. It's not the same as a blood transfusion, for example. But if you have repeated doses over a lifetime, you can have iron loading. And then I just show here that it works pretty quick. So let me just orient you to this graph. The y-axis is showing the concentration of those two intermediates in the recipe that I talked about, PPG and ALA. And it shows, okay, what happens to those levels when you give 4 daily doses of panhematin? And what you can see is that when a person has an attack, the level of those go up. And then very rapidly after starting hemin, the levels go down. And so typically people start to feel relief on about day 3 or day 4 of panhematin when it's given IV. And it fits very nicely with what we call the biochemical evidence, the amount of PPG and ALA that you can measure in a person's urine, for example. What about preventing an attack? So we talked about what are the treatments if you're having an attack. The kind of important things to think about in preventing an attack are to avoid the triggers. That's a straightforward one. We are really thoughtful about prompt treatments of infections or illnesses because those can trigger attacks in folks. I tell all my patients that they should avoid periods of prolonged fasting, carry around a power bar in the pocket, make sure that you don't have long periods when you're going without eating. And then there has been an off-label. The drug is not approved for this indication, but there is some data that giving hemin prophylactically to prevent an attack can be helpful. And the optimal dosing of that, you might say, well, how often do you have to get it to prevent attacks? That's not very well defined. Some patients get it every 2 weeks. Some people get it every monthly for a prevention of attacks. And then in individuals that have recurrent attacks, and usually this isn't a hard and fast rule, but we call recurrent attacks more than 2 attacks in a 6-month period. Again, that's kind of a rough rule of thumb. We can use givosiran, and I'll talk about givosiran in a second here. Very rarely in our patients who have recurrent attacks during their menstrual cycles. And it happens because during the menstrual cycle, the 7 days before the onset of menses, a hormone called progesterone surges. And progesterone is one of those triggers that we talked about to trigger an attack. And so rarely in menstruating individuals that have recurrent attacks with their menstrual cycles, I'll think about suppressing those menstrual cycles. And the reason I say rarely, you guys, is when you suppress the menstrual cycle, there can be a lot of side effects. It can increase the risk of thinning of the bones, osteoporosis, and people will have postmenopausal symptoms when you suppress menstrual cycles. So I would say I'm really thoughtful about that approach. I currently don't have any patients that I'm doing that in. I have prioritized using givosiran before that. And then again, very rarely, and I would say I personally have had only one patient, and this was before the advent of givosiran. If we have a person who's not responding to any therapies, the problem here we said was in the liver cells for the acute hepatic porphyrias. So a treatment is to say, gosh, we're going to correct the defect. We'll take the liver out and we'll give a new liver. So a liver transplantation is curative for AHPs, but it has lots of toxicity, lots of complications. So it's not something that we do commonly by any means. Okay, so then what about this drug, givosiran? So this is what's called a small interfering RNA, and it works by blocking that first step in the pathway that I had highlighted as kind of the rate limiting step in making heme and making that recipe. And it works by kind of using some natural processes that exist in the cell already of how we control the expression or how we control that first enzyme, ALAS1. And so the drug is targeted to go to the liver, it's taken up in the liver, and it decreases the amount of that first enzyme that's made, ALAS1. And it's indicated in patients that, again, have these recurrent attacks, typically about 2 attacks in a 6-month period. And it's a relatively new player on the field. It was approved in the US for individuals with recurrent attacks back in 2019. So what I'm kind of taking you through here is the big study that led to its approval. It's what's called a phase 3 study. It took patients with acute hepatic porphyrias, mostly patients that have had acute intermittent porphyria. There were a couple of patients with variegate porphyria, one patient with HCP, and it randomized them to either getting 2.5 milligrams per kilogram subcutaneously of the drug or just placebo, and said what happens in terms of their urine ALA and PPG, what happens in terms of their recurrent attacks, what happens in terms of their quality of life measures. So it looked at a lot of patient-reported data, and then also we had biochemical data. We said, what happened to the urine PPG and the ALA? And I'll say that after that initial randomization, the study had a longer term portion of the study where everybody got drug. And initially, people got one of 2 doses, either 2.5 or 1.25. And then it really looked like patients who received the 2.5 dose potentially had a better response. So everybody for the duration at the end of the study got 2.5 milligrams. And what I wanted to just show you here is kind of to give you a flair, a little bit of an idea of the data, the data on this trial and the outcome. So just orient yourself, you guys, quickly. On the y-axis is just the measurements of ALA and PPG in the urine. And so in that initial portion of the study, in the people who were receiving placebo, that's the red line on both of these measurements, their ALA and their PPG was very high in the urine. And those that got givosiran, you were able to drop their urinary ALA and PPG quite rapidly. The response is typically within the first month. The maximum response is at about 3 months. And then when you got to the portion of the study where everybody got drug, so the people who initially had been randomized to placebo could cross over and also get active drug, you see their urinary ALA and their urinary PPG dropped. And the study went out to about 36 months, so pretty good long-term data, and showed that there was a sustained biochemical data. And then I think probably more important to patients is when you looked at, did their attack rate drop? Yeah, it dropped. So the people who initially were on givosiran for the double-blind placebo, they had very few attacks, and if you kept them on it, they had very few attacks. And the folks that initially received placebo and were having 10 attacks or so a year, when they were crossed over to givosiran, that dropped pretty dramatically, a 92% reduction in the frequency of their attacks. So that was pretty encouraging. And I'll just say there was also kind of a few other endpoints to the trial. There were quality of life scores that patients reported. Did they just feel better on givosiran? And also they looked at how often did you have to give hemin to rescue a person if a person had an acute attack. And that also showed a benefit. So there was really a number of endpoints that looked great for this. The urine studies improved. People used less hemin for acute attacks. The number of attacks were reduced, and people reported improved quality of life. So what were the downsides? What were the side effects that were reported for this drug? I think the most common side effects are shown here. Nausea can happen, about 27% in the people that were getting givosiran versus 11% in placebo. Pretty commonly, it's a medicine that's given as a subcutaneous injection, so people could have localized reactions in the skin. I'd say these are generally pretty mild, you guys. People tolerate them, but they'll have a little injection site reaction. And then the other two things I always talk to folks about is there were increases in liver function tests. So ALT is a liver enzyme that we can measure when we're looking at the liver. And that was higher in the folks that got givosiran. Generally, those elevations were mild and they kind of improved over time. So I'd say we monitor the liver function. I look at the liver functions typically monthly for the first 6 months when I have a person on givosiran. Usually that's not something that limits our ability to use the drug. There was a change in the kidney function also observed in patients on givosiran. Again, that was pretty mild changes in the kidney function. And I kind of just put these in because, and we might get to this in the Q&A if folks ask about that. There were elevations in something called homocysteine, and you may or may not have heard about this in the community. And I'll kind of come back to that at the end, but homocysteine was elevated in the folks getting givosiran, and it really caused us to come back and look at that more broadly in patients with AHP. And what I would say is it's a little unclear if that's drug related or not. Patients that are not on givosiran that have acute hepatic porphyrias also have elevations in their homocysteine. And then the last thing that people wondered about was, this is a drug that works by stopping that first step in the heme pathway, the pathway that makes heme in your body. And heme is needed not only for hemoglobin to carry oxygen in your body, but heme is also used by a number of enzymes in your liver that help you to metabolize other drugs, a group of enzymes called the cytochromes. So think of those as machinery in the liver that when you take any medicine, your liver has to break down that medicine. And one of the concerns was, gosh, if you're messing with heme, and heme is needed for those enzymes in your liver to metabolize other drugs, might that cause complications in if you're taking an antidepressant or you're taking a high blood pressure pill or another medicine that needs to be broken down in the liver by those enzymes. And this initial study didn't look at that. There's been kind of one small study that did try and get at that question. Is there a problem with those enzymes that break down other drugs in your liver? And there is some complexity, you guys. The CYP1A2 and CYP2D6, just think of those as two of the enzymes in the liver that help to break down drugs, certain drugs, not all drugs. And so there are certain drugs that are broken down by these enzymes that your physicians are thoughtful about if you're also on givosiran. And we're kind of careful around that. I think the other thing I always highlight here is we don't have any significant data on the use of givosiran in pregnant or breastfeeding individuals. And so it's not recommended for pregnant or breastfeeding women, individuals, because we just don't know what the safety is in that context. And then the last thing, I'm just about done here, you guys, is kind of the acute hepatic porphyria surveillance and monitoring. And so patients with the AHP do have a slightly higher risk in their lifetime, a slightly higher risk of developing liver cancer, acute liver, what's called hepatocellular carcinoma. And so we consider liver cancer screening for our AHP patients when they're over 50 years of age. And that's done with a liver ultrasound and also a blood test called alpha fetoprotein every 6 months. And then the second thing is I monitor liver function and kidney tests because all patients with AHP have some risk of developing liver function test and kidney function test changes over a lifetime, at least annually, and more often on our patients with givosiran because it can impact those things. So I'm going to stop there, you guys. I just wanted to highlight, again, my clinic is part of a broader group of docs that are trying to advance the care of patients with porphyrias called the Porphyria Consortium. We started as something supported by the National Institute of Health called a rare disease consortium. And the website for kind of studies that are open by the Porphyria consortiums, I just put here. And again, I'm kind of way out on the West Coast. It's nice to join you all.
Wow, Dr. Keel, thank you so much for that knowledge. For the first time I have AIP, as I mentioned, for the first time, I actually understand what the heck happens in my body with this recipe, description. It really highlights what our bodies go through. And for the very first time, I finally understood the science behind it. So thank you very much. I'm sure that a lot of us had a lot of just light bulb moments like, oh, that's why my body does this. So thank you so much for explaining it in layman's terms for us to be able to really understand. Very impressive. Thank you so much. Let's jump straight into the questions because we are definitely loaded with questions and we want to take advantage for the next 20 minutes to answer as much as possible. The first question is, should I seek immediate heme infusions during an attack to avoid the toxic release in my nerves during a flare then? This was going back to your presentation of how it's so toxic when we are in a flare.
Yeah, so I think so we're talking about an acute attack, and again the question is, should we get hemin, and how urgent is it to get it right away? Should we get it with any inkling of discomfort? And I'll first say that there are patients that have milder attacks that they can control on their own. So I have some patients that when they start developing some discomfort, if they're thoughtful about eating, they take some pain medicines at home, they're able to stay outside of the clinic. I think the question is a great one, which is there any long-term consequence to if I have a little bit of pain and I don't knock that down right away? Is there some long-term consequence to my nerves? We don't really know that, you guys. That's a hard study to say. So I love the question, which is, gosh, is it better to be super, super prompt on the panhematin? My suspicion is that's not the case, that you have mechanisms in your body that quiet it down. And so in my patients, I really rely on their reporting of how severe their discomfort is on deciding, do we have to treat this? Do we have to have you come in to the clinic? And we're fortunate in Seattle because we will give the panhematin if a person's pain is not so severe that they need to be in the hospital for pain control. And we can kind of give them pain meds in the outpatient setting. We'll have them come in daily for the panhematin in our infusion center. If it's more severe, a person really needs to be getting also some IV hydration, may need anti-nauseas or pain meds, then we'll bring them into the hospital.
Thank you for answering that. Next question, should I get a port?
Yeah, that's a fair question. So just to step back, you guys, a port is a type of indwelling catheter, and you've probably seen different types of indwelling catheter. A port is placed subcutaneously on the chest, and the port goes into kind of right where the big blood vessel hits your heart. And similarly, if you have a PIC catheter, a peripherally inserted catheter, that's sometimes you see tubies hanging out here. The end of that catheter threads up right to where the big blood vessel hits the heart. And you don't, the reason to have an indwelling catheter, whether it's a port, a PIC, a Hickman catheter, but the reason the port, it tends to be more preferential is you can take a shower, it's subcutaneous, you don't have to wrap up the tubes. But for some individuals who require recurrent IV access, that you're getting poked all the time, the port can be helpful. It avoids you from getting poked a lot. The downsides of having a catheter, an indwelling catheter, they are serious. And so I think it's very individualized who should get a catheter. But the downsides of it is, one, it's a source for infection. And so people can develop bugs in their blood, and the catheter itself can get bugs coated on it. So an increased risk for infection. And then the second is whenever you put something that's foreign inside a blood vessel, it's the same thing as if you dam a river, right? That you kind of disrupt the blood flow in that area. And so there's a higher risk of developing a clot, what's called a catheter associated clot from having an indwelling line. So I'm really thoughtful about it. Panhematin can be given through a large bore peripheral IV. It can be, but it has to be a good IV access. And so I would say it's kind of a mix in my patient. I have some folks that have never had indwelling lines, have never had a port, and I've had some individuals that they just have small veins. It's hard to poke them, and they're either getting prophylactic panhematin or they're coming in a lot for labs or getting hospitalized. And in those settings, we just have a discussion about, hey, here's the pros and cons. Do we need to do that? And some people just, they're hard sticks. I think that can be a real reason to need a port.
Fantastic. If SRNI and AI are, let me read that again, sorry. If sRNAi blocks the ALS1 production, can we say since ALS-A1 is blocked, the eventual heme production also decreases in patients who are taking givosiran?
Yeah, it's a great question, you guys. So let me get a little kind of into it. So just think of it as the whole mechanism of action of this drug, givosiran, is it has an siRNA, and think of that as a mechanism to decrease the amount of that enzyme. And it's relatively liver specific. The way that the drug is made, it has a tag on it that is the receptor for that tag is on the liver cell. And so the drug goes to the liver, it's taken up predominantly in the liver. It's not 100% liver specific, but it's pretty liver specific. And so the question was, gosh, are you dropping heme synthesis in the liver? And the reason I love the question is it's very nuanced, you guys. The concern with the drug-drug interactions, let me come back to that, was in your liver, unrelated to porphyria at all. In your liver, you have these enzymes that metabolize drugs. They're called the cytochromes, and there's a whole bunch of these enzymes. And these enzymes are, for their function, they require heme. Heme is a part of, think of it as a building block of the enzyme in your liver. And so a concern was just what that great question was. Well, if you're dropping heme, what about other proteins that need heme? Are they not going to work as well? And it is true that it affects some of the cytochrome P450s, not all of them. So there has to be some degree of change in the quantity of heme, but it's not in a way that it's caused a lot of problems. In other words, the drug works. I use the phrase, we get away with it. In other words, the reduction isn't that significant that it has big impacts broadly. The second thing people might ask, and I'm going to just call this out, is you might say, well, wait a second, Dr. Keel, you said heme is needed for hemoglobin. That is this making me anemic? Is this going to drop my hemoglobin production? No. So that heme synthesis in your bone marrow is a different form of ALAS. In your liver, you have this thing called ALAS1. It's just call it one form of ALA. And that's a housekeeping gene. It's in or a housekeeping enzyme. It's in lots of your cells. But in your red cells, you have a special version of that called ALAS2. And so it doesn't block heme synthesis in your bone marrow, doesn't block heme synthesis in your red cells. So anemia is not something that happens with the drug. I hope that answered that one.
Yeah,
That
definitely.
was very technical for whoever asked that. I'm impressed. I'm not sure if they're a scientist because that was a lot of information.
Yeah, but it's a great question. I mean, there were lots of, I'll just say there were lots of questions around this, you guys. Another was, are you blocking ALAS1, for example, in the kidney? So one of the observations in the longitudinal data for the drug was there was a kind of an increased risk of kidney function changes. I don't want to overstate that, you guys. The changes in the kidney function were really mild, like not big time changes in the kidney function. But a question was, gosh, might it drop? There is a little bit of delivery of the drug to the kidney. And that was one question that came up. And I think at least in one person who had a kidney biopsy that was on the drug, they couldn't show that ALAS1 was reduced in the kidney. So I don't think we have good evidence that it dropped it there.
Wow, awesome. Thank you. For people who are experiencing recurring attacks around their cycles, are there preventions for females that could take maybe 7 days prior to their cycle, specific things in order to avoid a severe flare, maybe carb loading or something like that?
Yeah, those are great questions. So again, the kind of trigger here, we talked about the two triggers were either it directly turned on ALAS1 or it dropped heme, and heme normally inhibits ALS1. And so the kind of cycle related attacks happen when in a normal menstrual cycle, you have a surge in this hormone called progesterone. And that surge happens about 7 days before the onset of menses, before a person starts to have menstrual bleeding. And so some individuals suffer from recurrent attacks because of that progesterone surge, the progesterone. And so I would say kind of I've approached that in a few ways. If one is some women that have that, when I put them on prophylactic panhematin monthly, we've kind of timed the panhematin around their menstrual cycles just a little bit, and that can be helpful. I do not currently have any women on medications to suppress the menstrual or menstruating individuals. I don't have any of those individuals on meds to suppress the menstrual cycles. And that's just because I don't want to say that's a wrong approach. I just think it carries other side effects. If a person's menstrual cycles are suppressed, you affect a lot of hormonal things. And one of the things that is at risk is the development of bone thinning, osteoporosis. And then people feel postmenopausal symptoms. And so what I've just found is when I've tried that approach, the postmenopausal symptoms are so significant that the person doesn't have a benefit from it. I think being thoughtful, very thoughtful about not fasting in those periods of time. So doing the other things that can prevent triggers can also be helpful. And I'd say if people are really, let's say it happens a true attack every time, I would consider those recurrent attacks and I'd think about givosiran.
Okay. Is muscle twitching weeks after an attack, let's say the hands, the chin, the legs, very common? And if so, what helps to treat that symptom?
Yeah, that's a great question, you guys. And I don't have great answers for that. There's a lot of work that's happening, and I'm less of an expert on this. My background, I didn't kind of give you guys my background, but many of the porphyria providers are hepatologists, are liver docs. And I kind of came to the field, and there's a few of us in the field. I came to it as a hematologist. So I'm a person who thinks about blood. And the reason porphyria fell into my kind of wheelhouse is I started as a red cell biologist. So I studied heme synthesis. That's my kind of thing. And so that's a long, long prelude to say the neurotoxicities associated with the acute hepatic porphyrias. There's lots of work that's being done to try and understand why and how does that happen. And it is thought that it's the ALA that's most neurotoxic. And I would say that exactly what the findings in people are, I don't feel like we have a perfect grasp on it. What are the different types of nerve damage that people have and how best to approach that? So I don't have a great answer for that. I would say in my clinical experience, what you describe is what I hear from patients, that they can have nerve symptoms that are completely separated from their attacks. And how I've thought of it in not the most sophisticated way is that there is a long-term damage to the nerve, and that's described, but kind of exactly why that happens, what that nerve damage is, I'm not the best at explaining that, but I can say, to be encouraging, There are now neurologists that are working in this field, which is really cool because I think that's how we're going to get a better understanding of that.
Thank you very much. Going back to the presentation, you gave some data on what happens with the creatinine, while we're on Givlari. Was there any data for specifically patients with diabetes?
So what I would say is the not so much from off of that initial Envision study, but there have been other studies that have looked at least one that I'm aware of that looked at what we kind of call real world experience with a drug. So that's what happened after the drug became approved and docs are just using the drug out there. And individuals can report on their centers or many centers experiences in that setting. And I would say the little signal, and I don't want to overstate this because this is coming from real world data in a cohort of like 26 patients. So it's not giant numbers, but it's kind of where what I think about as a clinician in the clinic when I think about the possibility of kidney dysfunction from givosiran. There seems to be a signal maybe that the individuals that are more likely to have kidney injury are folks who have a baseline risk of kidney injury. And so those are people that have already kidney dysfunction. And oftentimes that can be with individuals that have diabetes or long-term hypertension. So I'm just really thoughtful in my folks that have baseline kidney dysfunction or risks independent of their porphyria of kidney disease, things like diabetes, high blood pressure, about monitoring their kidney and being really thoughtful about the other things that are needed for kidney health. So those are the people that I'm like, we got to make sure that we're on top of your blood pressure. We have to make sure that you lead a healthy lifestyle in other ways that are healthy for the kidney. So the big one is making sure their blood pressure is well controlled, making sure if they are diabetic, that their diabetes is well controlled.
Fantastic. We'll take two more questions, and we will then answer any additional questions later on. Specifically, you will receive a survey, and attached to that, or after that survey, we will send out specifically answers to some of these questions. In fact, Dr. Keel, if you don't mind, in the future, you could also maybe record yourself and answer these for us,
Sure.
because we do have quite a number left. So the question that I will pick here is, what would you suggest for someone who has high iron, whose porphyrin levels remain pretty high all the time?
Oh, so I'm going to rephrase it to make sure I understand it. So this is a person who has, sometimes we use the word high excretor. Their PPG and ALA levels stay high. And I don't know if this person's having recurrent symptoms or so or not, but they have high iron. And so in that setting, it kind of depends on how high the iron is, you guys. So we can assess iron loading in a person in two ways, and kind of whether you need both ways kind of depends on how severe the iron loading is. But the way that we know how much iron is in a person, kind of the cheap and dirty, is just to do a blood test called a ferritin. And a ferritin is a measure of your iron stores in your liver. And if that is markedly elevated, you can, and you want to have a more quantitative assessment of how much iron is in a person, you can do an MRI. You can say, I'm going to look by imaging of how much iron in there. That's hard to know for each individual person on the line. Do you need that or not? Usually the ferritin is an adequate assessment of iron. And depending on how high that is, you make a decision around, is it high enough that it's a risk or not? Just being above normal doesn't mean it's a problem. It has to be significantly above normal that it's leading to iron loading in tissues. And the tissues that get loaded with iron are your endocrine tissues. So your thyroid or your ovaries can get it, or the testicles can get iron loaded. The liver can get iron loading, and the heart can get iron loading. And so kind of decisions around what do you do with iron loading depends on how much it is, really. And if it's high enough, there's kind of a couple of things you can do. You can phlebotomize a person. You can take blood away from them by bleeding them, because the blood has iron in it. And there are medicines that can chelate the iron. So I think that's a kind of a very nuanced question of, first, is it really enough iron that it's worrisome, that it's a concerning amount of iron? And again, I just want to emphasize a little bit above normal. We usually don't think of significant to put it in a broad term. Generally, there is not significant iron loading if the ferritin is under 1,000. And so that's a loose rule, but that's kind of a rule of thumb.
Wow, thank you for that. I did not realize that it would also cause iron loading potentially in the thyroid and all these other places. So great information. Okay, and then the last question, if a person has controlled or stabilized AIP through givosiran and panhematin treatment, would they be eligible for top surgery?
Yeah, so kind of a question is, gosh, can a person with AIP go through a surgery that's is that safe? And I would say absolutely. You know, our patients that have AIP can have surgery. I always work really closely with our anesthesiologists, and that's because ahead of time you want to just make sure that any of the medicines that are given intraoperatively and the anesthesia, that they're safe for a person that has AIP, that they're not on the drug list of things that are potential triggers for porphyria. So I'd say the answer is I have a number of patients who have successfully gone through various surgeries. And again, I partner really closely with the anesthesiologist beforehand to say, hey, what's going to be the plan with anesthesia, with meds that this person receives for their surgery?
Perfect. Wonderful. Dr. Keel, thank you so much. What an incredible presentation, loaded with a ton of information. It really has been informative, not just for me, but I'm sure for everyone that's been sitting here and our caregivers as well. We are extremely, extremely blessed to have someone like you to be able to answer all of these questions that definitely fill our mind consistently. So let's keep a reminder that we will be answering all of your questions. They have been captured and they will be answered. So we will definitely be getting them over to you. And again, thank you so much, Dr. Keel. I'm going to go ahead and give the time over to Katri to wrap up. She is, again, our Director of Community Engagement. I'm sure that you have seen her everywhere in our socials. So take it away, Miss Katri.
Hello, everyone. I'm gonna share my screen so I can show you and present this. Can you see my screen, the
Yes,
presentation for upcoming events?
yes.
Okay. So first of all, thank you, Myra, and thank you, Dr. Keel, for taking the time to be with us today. And also thank you all for being here. First of all, the upcoming events, we have a special webinar on light protection in porphyria, an important topic for many of us. Also, join us for the Sunscape weekend, a getaway design especially for photosensitive children from ages 6 and 16 in North America. And there will be indoor activities and lots of fun. Plus, don't forget our WhatsApp Doc session with Dr. Bruce. Those are very important because all the questions we didn't answer today, we can bring them to the session, to the live session with this doctor, and he can answer all your questions. Then on May, let me change this. Okay, on May 18, we will be celebrating Global Porphyria Day, very special day for all of us. It's a key date where we aim to raise as much awareness as possible worldwide. So stay tuned for all the activities we're doing online. Then on October 12th, we'll be in Arlington for the International Porphyrias Symposium, Patient Day, and we'll love to see you there. Now, let's go to our resources, UPA resources. We have Connect Up, which are our small group meetups where patients can share their experiences and learn from each other. Then we have UPA one-on-one peer support. This is our newest program. I know that some of you here are already ambassadors and ready to help others, so thank you so much for that. But basically this program, it's about calling patients, stay up to date with them, help them, support them in any way they want, because of course, these usually are new patients trying to seek help because they don't know the diagnosis well, how does porphyria works, etc. So it's very, very important for us to help them. And then we have our amazing patient navigator, Erin, who is here to help anyone needing guidance with diagnosis, treatment options, or finding expert physicians. And finally, Porphyria Together. This is our private Facebook group with over 2,000 patients actively supporting each other, asking questions, and sharing valuable insights. So also, if you want your answer today, just drop it in the comments on For Porphyria Together, because there are a lot of people there answering questions and experiences. So it is very, very helpful. And well, lastly, we're here for you, and we hope you will join us in these initiatives. Thank you so much.
Thank you very much, Katri. And one other thing, we always love to highlight your story. We are all so unique in our ways that, this presents, how it affects us, and, information is power. So if there is anyone that wants to share their story, they have not gotten a chance to share it with us yet, I encourage you to reach out to either to Katri or to myself, and let's get your story out there. The more we create the noise that we exist and that this is real, and, we might look healthy on the outside, but only we know specifically the pain that we go through, it would be absolutely great for you to be able to be a voice in this very unknown, just, unknown, just disease that we live with.
Yeah.
So thank you for taking the time to learn with us today. Thank you for showing up. It really means the world to us to be able to have this community. It is important for us to remain together. So join the future webinars coming up. And most importantly, we're here for you. Like Audrey said, don't forget about that. Be safe and enjoy the rest of the weekend. Dr. Keel, once again, you're the best. Thank you.
Dr. Keel.